Good afternoon. My name is Matthew Noble, and our PLRP group is composed of Adriana Hughes, Sarah Jacob, Megan Holbrook, and Jose Espinosa. We were fortunate to have been selected to do our research at Moffitt Cancer Center for the past 3 years. We had great mentorship along the way, helping us out with our poster, which included Dr. Pasikova, Dr. Perkins, Dr. Snyder, and Dr. Baluch. The title of our project is called Incidence of Graft versus Host Disease in Patients After Treatment with Broad-Spectrum Antibiotics for Neutropenic Fever Following Allogeneic Hematopoietic Stem Cell Transplant.
The Infectious Disease Society of America recommends empiric IV monotherapy with an anti-pseudomonal beta-lactam for patients with neutropenic fever. Previous data has suggested a correlation between alterations in microbiome and incidence of gastrointestinal graft versus host disease. Anti-pseudomonal agents that also provide coverage against anaerobic organisms or addition of agents with anaerobic coverage may affect populations of both the harmful bacteria and the protective anaerobic gut microflora. The objective of our study was to describe the incidence of gastrointestinal graft versus host disease at 100 days post-transplant in patients who have been treated with empiric therapy with anaerobic coverage versus without for neutropenic fever post-allogeneic stem cell transplant from day 0 to day 30 or discharge.
IRB approved retrospective chart review that analyzed patients treated empirically for neutropenic fever following allogenic HSCT from June 1, 2014 to May 31, 2017 at Moffitt Cancer Center. 100 patients were analyzed from this time period. Patients were analyzed as two separate groups: those who were treated with medications that provided anaerobic coverage, which included cefepime and ceftazidime, and those that were treated with medications that do not provide anaerobic coverage. These included Zosyn, metronidazole-containing regimens, and meropenem. We analyzed baseline characteristics for gender, age at time of transplant, HCT comorbidity index, GVHD prophylaxis regimen, diagnosis, donor type, and conditioning regimen.
Group 1, without anaerobic coverage, was made up of 65 patients. A large majority of these patients were treated with cefepime. There were 35 patients in Group 2. Most patients were treated with piperacillin tazobactam, although a fair amount were treated with a regimen that included metronidazole. We did not find a significant difference in the incidence of graft versus host disease or gastrointestinal graft versus host disease.
The concept of our study was based on a relationship between the pathogenesis of gastrointestinal graft versus host disease and the intestinal microbiota. Our study contributes to a small body of literature that exists in the area of bone marrow transplant and graft versus host disease. In the future, it would be beneficial to include larger sample sizes, specifically focused on the analysis of the incidence of gastrointestinal graft versus host disease. Our study had some limitations, such as being a single-center study, and that the research relied on accurate documentation, which is naturally prone to having errors. On the other hand, some of the strengths of our study include analyzing treatment regimens and outcomes in pragmatic setting, studying an underrepresented patient population in the literature, and lastly, having a well-defined inclusion and exclusion criteria. We hope that you like our research. What questions do you have for us?